Hello, my name is Meg Monday, and I'm the Director of Educational Programming on Cancer Connect. I want to thank you for joining us today for a live chat with Dr. Mark Kozloff from the University of Chicago on early stage colon cancer, making informed decisions. Dr. Kozloff is a clinical associate of medicine in the Center for Gastrointestinal Oncology at the University of Chicago. He works on a multidisciplinary team of experts in the Center for Gastrointestinal Oncology, where he specializes in the treatment of colorectal malignancies. Dr. Kozloff's clinical research focuses on new drug developments for colorectal, pancreatic, and lung cancer. He has co-authored more than 100 scientific papers, abstracts, and letters examining the efficacy, safety, and effects of drug therapies for cancer. We're very excited to have Dr. Kozloff as today's expert. Thanks again for joining us today, and I will now turn the presentation over to Dr. Kozloff.
Good evening. I would like to thank the people who have joined us tonight for being here. I'm Dr. Mark Kozloff. I'm a clinical associate professor of medicine at the University of Chicago. I work in the gastrointestinal oncology branch at the university. And this is a live webcast for cancerconnect.com. So again, thank you for being. We're going to talk about early stage colon cancer, how to make decisions. Just to give you some background, colon cancer is the third leading cause of cancer in the United States. It's the second cause of cancer death in the United States, second to that of lung cancer. There's 103,000 new cases of colon cancer each year. Approximately 50% of the people who get colon cancer will die from it. The mortality rates have declined by about 3% per year since 1998. So we are doing things better. And I think it has to do with two reasons. One is early detection, finding the disease earlier. That allows us to treat better, earlier stage, giving us a higher cure rate. And our adjuvant therapies, how we've given chemotherapy after surgery, has actually improved the cure rate for each stage that we have given it to. To talk about screening and early diagnosis, certainly there are things that should be done, but screening should start at the age of 50. People who are at increased risk should start beginning earlier. If you have a family history or a predictive genetic test that shows that you're at increased risk, certainly you should start doing this, and it could be anywhere from the age of 40 to 45. Screening strategies could be anywhere from having a stool checked for blood to that of colonoscopies. Colonoscopies has actually caused a risk of reduction in colorectal cancer by about 67%, and the death from colon cancer by 65%. Fecal occult blood test gives about a 1/3 or 33% reduction in mortality. Flexible sigmoidoscopy, a 33% reduction in incidence and a 43% reduction in CRC mortality. And doing a barium enema as well as fecal FIT or immunochemical testing have all shown to be beneficial. Certainly, I would highly recommend doing screening and starting at the age of 50, because this has definitely been shown to either prevent colorectal cancer or to catch it early enough where we can increase the cure rates. Now, what are things that can increase your risk? Certainly having what's called FAP or FAP, familial adenomatous polyposis, is a family hereditary syndrome that accounts for about 1% of colorectal cancer. And Lynch syndrome, which is another hereditary colorectal cancer syndrome, accounts for about 5% of all colon cancers. Certainly, if you get colon cancer or there's a history of colon cancer at a young age or a strong history of colon cancer, one should have the family checked for one of these hereditary syndromes. Other factors that can increase your risk of developing colon cancer is having inflammatory bowel disease, which is colitis, having a low fiber diet, having a lot of red meat in your diet, obesity, and certainly smoking all increase your risk of developing colorectal cancer. So once a diagnosis is made, certainly one should have the disease treated. The mainstay of having treatment for early stage colorectal cancer is that of surgery. And depending upon where the cancer is, we do have options. Certainly having a colectomy or having that part of the colon removed with either a hemicolectomy by open technique or laparoscopic, where they put three little incisions and take a scope and put it in the abdomen, are what we call minimally invasive, can be very helpful. But certainly one should consider surgery as a mainstay for that of early stage. And if you get the disease early enough, like stage 1 disease, where it doesn't penetrate into the colon hardly at all, but stays in what we call the superficial mucosa, about 90% of the patients do get cured. Stage 2, approximately 80%. So catching it at an early stage really does increase your chances of being cured. Certainly, there are ways of looking at adjuvant settings or individualizing treatments, and one should look at the patient in total to make these decisions. Certainly looking at how much disease is present, what we call the stage of the illness, looking at the health of the person. Are there comorbidities? Is there diabetes, heart disease? Is the person frail? These are all things that one takes into account. Age is something else that can be taken into account, but I'd like to say that being older shouldn't stop a person from being treated. I think that one should look at the age or the what we call the chronology of the person, and not have that be a problem. One should look at the health of that person to make decisions. There's something called MMR status, and that's basically a what's called mixed match repair gene. That's a gene or genetic abnormality, not of the person, but of the cancer, that can tell us what the risk of something coming back, and one can make a decision based on that. And having either a high or low grade cancer can help make decisions on further treatment. Recently, in the last couple of years, we've actually been able to take the tumor, check the cancer, the genetic makeup of the cancer, what we call molecular profiling, that can also tell us the risk of the cancer coming back, that can help us decide if adjuvant chemotherapy should be given on top of that of surgery. So certainly looking at the person, looking at the cancer, especially if one looks at how the cancer is made, can help us determine if further treatment should or should not be given. Certainly looking at stage 2, we can look at stage 2 where it goes through the wall of the bowel, but it does not go to any lymph nodes. And one can look at low risk, standard risk, and high risk to make decisions. Should any other therapy be given? Should chemotherapy be given on top of that of surgery? All the stage 2s should have surgery. Some of them should get chemo, and some of them should not. And looking at the size of the tumor, the T size, looking at the genetics of the cancer, what's called the MMR, and looking at maybe the molecular DNA, what we call recurrence score, can help us determine if one should be on further treatment versus just that of surgery alone. So one looks at the cancer, the size of it, what kind of qualities of the cancer, the genetics of the cancer, and information about the person to make decisions as we go forward. So one can then look at stage 3. Most of these patients should get chemotherapy for that of after surgery, because this has definitely been shown to cut down the risk of the cancer coming back. And one can increase the chances of cure by giving chemo after that of surgery. We can split up these stage 3 patients into either low risk or high risk, and that depends upon how many lymph nodes are positive. Again, stage 1 is when the disease is confined to the colon, very superficial. Stage 2 is when it is confined to the colon but eats through the colon but does not go to lymph nodes. Stage 3 is when it goes through the colon to lymph nodes. And stage 4 is when it goes to other places like the liver or lung. Certainly, stage 1, 2, and 3, the mainstay of therapy is surgery, and one should look in these patients for possible chemotherapy depending upon what their risk of recurrence is. Now let's look at that of molecular profiling. Again, it's looking at DNA or something of the cancer that is different from normal cells. And each patient will have a risk of recurrence. Not every cancer behaves the same way. And by doing either an Anka Type DX colon cancer assay or something called Coloprint, one can further define the chances of the cancer coming back, what we call prognosis, that can help us determine if any other treatment should be given, such as chemotherapy, after that of surgery. Once you make the decision about treatment in stage 2 or stage 3, one does have options for adjuvant therapy. Certainly if a person's low risk, observation can be done. If a person's at a higher risk, we have either one drug that we can give, either 5-FU or a drug called capecitabine. Capecitabine is oral, 5-FU is intravenous, goes through the veins. And if a person's extremely high risk, such as in stage 3, one can give 2 drugs, such as 5-FU plus a drug called oxaliplatinum. These drugs have definitely been shown in patients who are at risk to have the cancer come back, that you can cut down that risk of the cancer coming back, increasing what we call the disease-free survival, as well as the overall survival, and cut down the chances of a cancer coming back. Certainly one thing I would recommend is that if there's a clinical trial available looking at newer treatments or looking at length of stay or how these drugs can be given most optimally, I would highly recommend clinical trials. It's through clinical trials that we have made progress in colon cancer, lung cancer, and other cancers for finding the best treatment and increasing a chance of the patient being cured. Now let's look at this Anka Type DX. This is a new test that's been around for just a couple of years, and it can give you what's called a recurrence score. It looks at the DNA, and it can tell you if a person has a low risk of the cancer coming back versus a higher risk. It doesn't tell you who will respond and who won't respond to chemotherapy, but we do know that people who have a higher chance of the cancer coming back will get more benefit from chemotherapy, and we know that people who have a lower risk of the cancer coming back will have less benefits from chemotherapy. So this can sometimes help some people make a decision if they should get adjuvant chemotherapy, again, chemotherapy after surgery, to increase the chances of cure. Because we know in some people, giving chemotherapy may only give a 1 to 2% benefit, and we know in other patients that giving chemotherapy can give a 15% chance of giving benefits, or even up to 20% of increasing their potential cure from that of cancer if they get chemotherapy. A recurrence score can help you define the risks of the cancer coming back. That may help you decide on adjuvant chemotherapy, yes or no. So once the ways to improve treatments, decrease the chances of cancer death, is to find the cancer earlier, to make the diagnostic tests even better. And I know that in the future, we hope to have a blood test or even checking the stool for DNA that may tell us even how to pick up the cancer earlier, easier than going through a colonoscopy. Certainly, developing new drugs can be extremely helpful at fighting off cancers. And at the present time in our research, we're looking at several new drugs that are what we call targeted treatments. They look at specifically something that's on the cancer or different from the cancer from normal cells. We're able to make a specific treatment for that abnormality that will individualize a person's treatment, where it's something will attack the cancer more than will affect normal cells. Again, something called targeted therapies, and these things are being looked at in clinical trials at the present time. And this hopefully will give us new targeted treatments, biochemical treatments, as well as chemotherapy drugs that will allow us to treat colon cancer and other cancers in a better way that would then increase the chances of the cancer not coming back, and again, increasing the chances of a cure. Certainly, there are a number of these new investigational drugs and treatments that are being looked at throughout the country. I would say that the last time I looked in colon cancer, there was about 100 to 150 new trials that people were looking at to then, again, to increase how a person does, to increase the benefits, decrease the toxicities of treatment, so a person will do better. So with that, I'd like to say that is somewhat of a background that is in early stage colorectal cancer, certainly, excuse me, doing to check the person to catch the disease earlier, to optimize the treatments through surgery, defining the risk of recurrence, and then potentially giving adjuvant therapy, specifically in the future and now targeted treatments that will then increase the chances of a person doing well, as well as decreasing the chances of a person's cancer coming back and decreasing the side effects of treatments. And certainly doing the genomics, such as Anka Type DX or Coloprint, can be very helpful at defining the risk of the cancer coming back. So with that, I'd like to open up for questions and answers. I do have approximately 10 questions that have been asked, and I will go through those and answer them at this present time. From Medford, New York, the first question is, do I need to see an oncologist if I had stage 1 colon cancer that was surgically removed? And the answer is no, you don't need to see an oncologist. The chances of you being cured is quite high, and certainly that need for any adjuvant chemotherapy is not there. But you will need to be followed up by your surgeon or your GI doctor to make sure that nothing else develops, and you will need routine checking or testing in the future. Once you've had a history of colon cancer, you should probably get colonoscopies about every 3 years thereafter to make sure that you don't develop a new cancer. The next question is from Brandon, MS. What is MS? Missouri. I'm sorry about that. Is what is the best kind of surgery for a colon resection? Well, the best kind of surgery for colon cancer is one that removes the cancer plus at least 12 lymph nodes. That can be done openly, where they make an incision and they do what's called a hemicolectomy, where they remove a pretty large proportion of the colon and the surrounding lymph nodes to the tumor. And one wants to make sure that they at least get 12 lymph nodes, because if they do less, one can have a worse prognosis. So you need to make sure that you get the tumor plus a margin of normal tissue plus the surrounding lymph nodes. This can either be done openly or can be done laparoscopically, where they put what looks like a periscope into the abdomen. They see where the tumor is, and using tools that can go through the periscope, one can then potentially remove that part of the colon and those lymph nodes. The next question is from St. Michael's, Minnesota, that says, I had stage 1 colon cancer. What are the chances that my cancer will come back? It's less than 10%. And every year that you go without the cancer coming back, those odds increase more. But certainly your chances of being cured are quite high with stage 1 disease. The next question, or the fifth question, is from Yardley, Pennsylvania. How did I get colon cancer? I eat well and exercise. So scared of surgery. Should I be worried? Well, I can tell you that in most instances, we can't tell a person why they've developed colon cancer. We know in a small percent of patients, about 6 to 7%, it can be hereditary. Certainly, in the majority of cases, we don't know why, but certainly how a person eats, what smoking, obesity, history of colitis all increase to your risk. Certainly, one should eat well, not smoke, and you can decrease your chances. But even with that, one can't guarantee you that you won't get colon cancer. And that's why people who even eat well are not at risk still should be checked with a colonoscopy starting at the age of 50. Again, you should be getting surgery. Should you be scared of having surgery? The answer is one should always be concerned when they get surgery, but it's the treatment that should be given. And nowadays, surgery can be given very safely. So in the great majority of people, it should be given, it can be done very safely, and a person can have a good outcome. But I can't tell a person they shouldn't be concerned about having surgery. The next question is number 6, is from Baldwin, New York. I have stage 2 colon cancer. Remember, that's where it's still localized to the colon, but it eats into the colon further. I have read about Anka Type on your site. How do I get this test? My doctor hasn't said anything about it so far. Well, I think it's something you should talk with your oncologist or your doctor about. I think, once again, this is a test that can help further define the risk of recurrence. If you take all stage 2 patients, the risk, and you just do surgery, the risk of the cancer coming back is somewhere around 20%. Could be as high as 20, could be a little bit higher on average. Now, if you do Anka Type DX, it can further define the risk of the cancer coming back and may tell you that your risk is only 10%, or it can tell you that it might be 35%. So it can better define the risk, and one, depending upon that risk, may or may not make a decision about taking adjuvant chemotherapy. Again, something like this should be discussed with your oncologist. The question of having the test should be discussed with them. And this test then should be used, hopefully, to make an informed decision. Should you or should you not be on adjuvant chemotherapy to cut down your risk of the cancer coming back? The seventh question is from Long Beach, California. So we're going from the East Coast now to the West Coast. Can cancer return after resection and lymph nodes taken out? And could it return in other parts of the body? And the answer is yes, that cancers can return and come back after surgery. And so going through cancer surgery doesn't guarantee your chances of being cured. The cancer can come back after this. The reason for going through adjuvant chemotherapy is it decreases the risk of the cancer coming back in other parts of the body, but it doesn't guarantee it. The most likely places for the cancer to come back may be the liver, the lymph nodes, or the lung, and these places should be watched very closely by your doctor. The next is from Third Lake, Illinois. I'm from Illinois, and I have to be honest with you, I don't know where Third Lake is. I'll probably look it up after I give the talk. But the question is, I just found out that I have Lynch syndrome. This puts me at higher risk than the normal population for colon cancer. What is the best thing I can do to improve my chances of not getting colon cancer or catching it when it is early? Thank you so much for answering my questions. If you have Lynch syndrome, it includes colon cancer. It can include other types of cancers as well, such as uterine cancer. So one needs to be screened very closely for these cancers by having colonoscopies more frequently, having gynecologic exams and maybe ultrasounds more frequently, potentially to have a hysterectomy at an earlier age, can all be done to either catch the cancer early or potentially cut down your risk. The other thing that one should do is definitely eat a good diet, high fiber, low fat diet that has a lot of fresh vegetables, has a lot of fruit, and exercise are all things you can do to cut down your risk. I would also suggest taking an aspirin every day because I feel that can also decrease your risk of getting colon cancer. But again, if you have Lynch syndrome, you should, with your doctor, have a set of tests that you get, not only for your colon, but other parts of the body. So one can, if you do develop cancer, you can catch it at a very early stage. The ninth question is from Norwood, MA. Should I have a CT PET scan after surgery for stage 1 colon cancer? Any other tests? And I would not suggest doing routine CAT and PET scans after stage 1. Certainly, I think following up with CAT scans for stage 2 or stage 3 can be done, but I think the risk of having the cancer come back for stage 1 is so low that routine CAT scans should not be done. And the last question I have here is from Portland, Oregon. How do I get an Anka Type test done? And what I would say is, again, it's something that you should discuss with your oncologist or your surgeon. They can then send your tumor to Genomic Health that's in California that can, on the tissue, do this Anka Type DX, send back a form that will give you a number, what's called a recurrence score. That will tell you your risk of the cancer coming back within 3 to 5 years. And using that information, you can make a decision about further treatments with adjuvant chemo or no chemotherapy. Okay, those are some of the questions I have. I have one more that are FOLFOX and KBOX comparable regarding effectiveness in lowering the risk of recurrence. And the answer is yes, they're very comparable. Both drugs, both of those regimens, KBOX and FOLFOX, have oxaliplatin in it. One has 5-FU and the other one has capecitabine in it, and they both are very comparable of decreasing the risk of the cancer coming back in stage 3 patients. In stage 2 patients, it's not a standard of care at the present time, except in the higher risk stage 2 patients. Another question is, in 2007, I had colon surgery after a colonoscopy, found a cancerous polyp. Diagnosed as stage 1. No cancer cells found in the area of surgery. Had 1-year follow-up in 2008, second follow-up in 2010. When should the third follow-up be? I've been told 2013 and 2015. Well, I'd like to say that a follow-up that you should have, you should be seeing your doctor probably on a routine basis of about every 6 months. But I believe that you should only have a colonoscopy about every 3 years. The next question is, on his last slide before Q&A.
Oh, wait.
Oh, I'm sorry. That wasn't a question. I apologize.
That's okay.
The Anka Type was developed for stage 2. However, they looked at stage 3 patients most recently in what we call an NSABP study, and they've actually shown that in stage 3 as well as stage 2, that Anka Type DX can help further define the chances of the cancer coming back. It doesn't tell you who will respond well or not respond well to adjuvant therapy, but it will give you both in stage 2 and stage 3 that of better defining the prognosis and the chances of the cancer coming back. Okay, that is the last question we got. I would like to thank everyone who basically came in and listened to me tonight. I know that some of the questions were very personal and had to do with people's own cancers. I would like to say, for those who do have colon cancer, I wish all of you, and I actually pray for all of you, to do well, and that you do, and that things work out very well between you and your doctors, and your treatments are highly successful. So that is one thing I wish for all of you. The last thing is, I would like to wish all of you a Merry Christmas, a Happy New Year, and may 2013 be very healthy for you and your families. Thank you for being here tonight.